Hey Refam, my name's Kate and welcome back to My Surgeon Says, a podcast with real surgeons, real experiences and real advice. Today we're getting into the world of combination surgery. Richard and Kim reveal whether combining surgeries is actually the cheaper option, which two procedures they would never do at the same time, and whether recovery is easier for single or combo operations. As always, please rate and review wherever you're listening or watching. It really helps people find our little podcast. Welcome to Recommendation Corner, a very important segment where we just talk about things that we've done recently or that we think are good for the people to get around. Kim, kick us off.
Amazing restaurant I went to over the weekend, well worth going. It's called Yaga and it's in Fitzroy Gardens, the most beautiful custom-made building. It's just stunning, even if you don't go to the restaurant. Go for a walk around Fitzroy Gardens and have a look past it. Very Australian, all Australian made products, all Australian sourced food, local as possible. Just a beautiful experience from start to finish. All the staff were amazing. The food was amazing.
What was your favourite dish?
Oh, it's so hard, but probably the secret dessert that you have to figure out which bit is actually the dessert. It looks like a bush.
Richard?
Last few years, Lisa and I have got into hiking and we've just come back from the Bay of Fires hike, which is a really fun hike, mostly along the beach and a bit of kayaking, which we did as a family. So highly recommend. Good activity, no connectivity for a few days, which is frustrating, but probably good to do every once in a while.
Mine, again, a combo of the both, but the Port Arlington Mussel Tour, if anybody's in Victoria or visiting Victoria, it's only like an hour away from Melbourne. And you can either catch the ferry from Docklands or you can drive down and it's so easy. But the people are lovely. The food is so good. You get to go get the mussels off the way where they breed them. You learn a lot about mussel farming and it's very sustainable.
Wow.
Not the boat bit, but how they do it. All right. Seamless segue. Today we're talking about combination surgeries. So I know it sounds pretty straightforward, but what is a combination surgery? What actually defines that term?
It's just when we're doing two operations on two different parts of the body or even sometimes on the same part of the body. Example of that would be, say, a breast lift and breast implants. So that would be a combination procedure. So two different procedures in the same operation is the best way to think about it.
And are there certain procedures that are commonly done together?
You can quite commonly do a breast procedure and a tummy procedure.
Do you have any patients that you think have like really benefited from doing two different procedures in the same sitting?
Well, it's actually interesting. Some surgeons would see a body lift actually as a combination procedure. So they would do a tummy tuck and then come back and do the back lift, whereas we would never do that really. We always do that as a combined operation as a body lift. So in terms of then leading into that question, I think just as an operation for patients after significant weight loss, doing a body lift procedure really addresses that whole lower trunk. I think for surgeons who don't commonly do those procedures, they're not often assessing the 360 degree of the trunk. And so I think doing those together, they complement each other. I think you get a better result from the front, the abdominal part of the surgery, but reducing that fullness in the lower back and correcting the buttock ptosis, I think then gives it a much better overall result to the lower trunk. It helps with clothes, and if you want to call that a combination procedure, I think that's certainly a winner from my point of view.
Yeah, and on a similar perspective, the breast reduction that extends around to do a upper back lift or a bra line lift is a very similar type of combination procedure where if someone's got large breasts but also excess skin on the side of their chest or excess skin on their back, if you just deal with the breasts alone, they're still going to have residual, almost like an extra boob on the side of their body. So again, assessing that whole 360 at that first consultation, saying, look, sure, your breasts are big, but what you're not noticing is how much excess there is on the side, so much because your breasts are so big. And if we only address the breast and not the side, then you're going to have a different problem. That's something that we're probably increasingly doing that as a combination procedure as well.
How common is the upper back lift?
Not super common, but not super rare either.
Okay. It's funny. I just feel like I always see lower back lifts as a part of the lower body lift, but it feels a lot rarer to see the upper back lift ones?
Yeah, I think a lower back lift is more common than an upper back lift, but I think there just ends up being more skin on the side of the hips rather than on the side of the chest.
Yeah, right.
But if you're not looking for it, you're not going to be seeing it either.
Yeah, definitely. Okay, obviously, if people want to get more than one done at once, that sounds great, but not every procedure, that's a possibility. Which procedures really do not work together at all?
I think you're compromising your results if you do a trunk tightening procedure like an abdominoplasty or a body lift with thigh reduction. Because when you're doing particularly a body lift, you're lifting often a lot of that thigh skin, which is excess skin. And if you try and combine that with a thigh lift, then you're pulling in opposite directions. So I always, well, the exception makes the rule. So I actually just saw a patient who I did a thigh reduction on prior to doing her body lift as her preference. But my preference is always to do a body lift procedure prior to doing a thigh reduction, because it sets the foundations really for what skin is in excess in the thigh. So you're removing the correct amount of skin and they're not competing against each other for tension.
And pretty much never doing them in combination. Like,
yeah,
I have as well done a few where I've done the patient wanted the thighs first and then you come back and do the lower body lift. But I don't think I've ever done lower body lift and thighs in the same operation.
Yeah.
And the other thing that I would always say no to is if a patient wants everything done in one go, like arms, breasts, tummy, thighs, and it's like it's technically possible, but it's unsafe, I think, and it's too long under anaesthetic and just would be a near impossible recovery, I think, because they're like all their limbs and all their body have been operated on, so like moving and getting them going would be problematic.
And a bit of a red flag as to what they actually want, like what they need, you know what I mean? If it's just like, I just want a full body transplant, maybe. So can you share a time that you have said no to somebody who was determined to have a combination surgery?
Oh, I think it's those sorts of patients that Kim's just alluding to, who've lost a lot of weight. And it's quite daunting at the first consultation, because particularly if you've lost more than 30, 40, 50, 60 kilos, there's just loose skin, arms, breast, upper back, lower back, tummy, thighs, maybe face. And so you just need to rationalise that. It's a bit of a combination of what are the patient's main concerns, along with setting a long-term goal and then trying to prioritise the best course for the patient. But I often try and map out what the first operation is, what the second would be, what the third would be. And in terms of what I would do in one go, I more limit it by areas than time. So I would do 2 areas, but not 3. So I do body and breast, or body and arms, or arms and thighs, but I wouldn't do body, breast and arms. But yeah, some of those operations take 8 hours. So there's a time factor as well.
Have you ever had patients push back who are determined to have a combined surgery, but you've recommended a staggered?
I think probably the most common one for me is when patients need both a lift and implants. And there's a certain percentage of those patients where you can combine them safely. I've got my guidelines for how I make that decision, which involves not having to lift the nipple too far, not having too big an implant, because obviously then there's more tension on the skin, and also how big the areola is makes it more difficult to try and combine them. And the issue with those 2 operations is, one is with the implant is expanding the skin, and the mastopexy is tightening the skin, so they're competing. So you need to be very careful in the patients you choose to do them as a single operation. So I've no doubt recommended that. And different surgeons have different thresholds for when they would do that or not do it. I think massive weight loss patients are particularly difficult to do that in one stage because their skin elasticity is so poor. So I've got no doubt I have recommended that in the past, and then they've found a surgeon who would do it in one go. Vast majority of patients are sensible. If you explain your rationale for why you think it's safer to do it in 2 stages, then they're usually comfortable. But if I'm not prepared to do it, then I don't get forced into doing it.
When I explain it to patients, I say that I can get more predictable results in planned 2 surgeries rather than one surgery where you try to do too much and then you have to do an unplanned revision. So they're still ending up having 2 surgeries because you're revising them, but the revision is then more complicated and less likely to give them the best outcome than if you plan it as 2 surgeries.
Yeah.
So someone who's coming in with very droopy breasts and wanting an implant have expectation to get the same result as a primary breast augmentation.
Yeah.
And so you basically have to create the situation which is
A normal
same
breast to start with.
Exactly. So the same breast platform that you would be operating on in someone who has no breast droopiness, who has a perfect shape. You need to create that first, because their expectation is to get the same result as a 22-year-old coming in who has never breastfed or had any weight fluctuation.
And I think most of the patients that we see are actually extremely reasonable about that. Like once you explain, I'm not doing 2 operations because I want to do 2 operations. I want to do 2 operations because that can give you absolutely the best possible outcome. And I guess those ones that maybe would be pushing back to us that we're going to say no anyway are potentially going elsewhere.
With combination surgeries, do you think there's like an appetite for it at the moment? Do you think it kind of waxes and wanes? It's gotten more popular since you've come. What do you think impacts it?
I think overall anaesthetics have become safer. We've got more techniques to keep patients warm. So some of the issues with longer operation is fluid balance management. So that's always been pretty straightforward. A lot of patients having these bigger operations will have a urinary catheter so we can monitor their fluids. Temperature control becomes a much bigger issue in a longer operation. So you've got much more of the body exposed for a longer time. Theatres, particularly mine, are usually cool because we're in theatre gowns and under the hot lights. But we've now got techniques to be able to keep patients warm. And some people love this, some people don't love this. We pre-warm patients. So some people find it gets really too hot, but a lot of patients actually quite like it under the hot dog blanket before surgery. And then there's other things like pressure care. So there's much more awareness, and because we're doing this all the time, the staff in theatre are looking out for all of those things. And then there are some maybe side issues, infection, and I'm not sure that really is increased with longer operations.
Manage their pain better as well, because we tend to inject local anaesthetic during the surgery, and that also has a combination of adrenaline in it as well to decrease some of that blood loss too. So you'd imagine if you had all parts of your body operated on, like, it's going to be pretty sore, but if you've got adequate pain relief, which isn't completely knocking you out and making you bedbound. So I think those techniques have developed better over time as well.
So do you think that recovery for a combination surgery is pretty similar to recovery for staggered surgeries?
If I am talking to a patient that's having a breast and a tummy procedure, I pretty much tell them that the breast they're not going to notice because the recovery is all about the tummy. So if they're thinking that the recovery is going to be double because they're having the 2 procedures, almost like you get the breast recovery for free. Whereas if you're having them split, then you've got 2 lots of 6 weeks of recovery versus 1 lot of 6 weeks if you're having them done together.
Do you think a combination surgery, on that note, is more cost effective, less cost effective than staggering the surgery, or what are the hidden costs patients have to look out for?
So I think it is a bit of a myth that if you're doing the operations separately, that it's going to cost more. A lot of discretionary surgery, for want of a better term, is time-based. So our fees don't change whether we're doing a breast reduction as a standalone procedure or with an abdominoplasty. And the hospital, so for patients who are self-funded, whether we're doing them together or separately, it's how many minutes you're in theatre. So whether that's over 1 operation or 2 operations, it doesn't really make a difference. I think the main probably cost benefit in a single surgery is the time off work. So it's an opportunity cost that you're losing if you're having 2 recovery periods, because no matter what you're doing, you're probably going to be at least 3 weeks off work. I agree with what Kim was just saying about an abdominoplasty with or without a breast surgery. I think the recovery is similar. But if you had a breast reduction as a standalone, you're still going to have another 2 or 3 weeks off work. But if we're recommending them separately, or you want them separately for personal reasons, well, I don't think it makes a huge difference.
I think it's like much of muchness.
Yeah.
Is there a point where adding just one more thing becomes unsafe?
Absolutely. So it depends what the add-on is, but even something like liposuction is still surgery. So no matter what body part, unless it was part of your abdominoplasty or part of your breast reduction, I would generally, obviously patient dependent, would be like, no, that's not something that would be adding on at the time. The other thing that I wouldn't do in combination together is a lower body lift and a breast reduction and an upper back lift, because essentially that's like cutting you in around all the way around twice. And we had this conversation recently. I was like, would you ever do that? And yeah, we'd either do the lower body lift and the breast reduction, come back, maybe do the upper back, or split the two procedures completely. And often if a patient needs both of those things, each one is a pretty big procedure on its own. And we've talked quite a bit about lower body lift and breast reduction, but I still would have some patients where I'd say, look, your lower body lift is significant and I'm going to do that completely on its own. So whilst there are a bunch of patients that are suitable for, it's very personal.
Speaking of it being patient dependent, how does that factor in? What are your assessment criteria? I know obviously it's going to be a little bit different per surgery, but generally speaking, what are you looking out for when you're assessing a patient for if they're fit to have combination surgery?
So a few things, comorbidity, uncommon in our patient population, but some of the things that would maybe impact it would be if they've got any bleeding disorders, so a propensity to bleed more or clot more. So you probably want to limit how much you're doing in those circumstances. Other things like diabetes or heart disease are just very uncommon in our patient population. I think really extreme weight loss, and like I know we're talking about massive, but I'm talking about body weight level weight loss. There's so much excess skin. It's very hard to combine those sorts of procedures. Age maybe comes into it to a certain degree, although I just saw a patient done a body lift and breast reduction. She was 65, not that 65's old.
They have to be suitable for each procedure separately before you can combine them. So stable weight, each area has to be appropriate for the procedure that they want.
It's hard what you said as well with the massive weight loss, because obviously they're the people who probably are the most eager to combine, because it's like they're the ones being most impacted by that excess skin. But it's like, which actually, beautiful segue, Kate. Does combining procedures impact the results?
Well, the aim is that it shouldn't. The reason behind the reason that we were saying to not combine surgery is if it's going to impact the result on top of safety and other issues that we're talking about.
Yeah. And those extreme massive weight loss ones that we're talking about, when we see a patient when they first come in, it's not us trying to upsell you more operations. It's like, what areas bother you, even if you are only considering getting your tummy in the short term, but you're considering arms and breasts at some stage in the future, just tell us the bits that bother you total. And then we can talk through the best way to actually do those. Because if you say, look, I only want my tummy, and we do that, and then 6 months later you come back, like, I only want my breasts, and then 6 months later I only want my arms, like, you could have actually probably had some combinations to get you to your endpoint, either in less procedures or in a shorter time frame. And with those patients, we make a treatment plan. And as you said earlier, like sometimes you're actually making a plan of 3 procedures. If anything is compromised, or with that really stretchy skin, there's some laxity or some more skin that becomes obvious in an area you've already operated on, you do have an opportunity to do a revision. Say the third operation's the arms and thighs, and if they've got a scar on their breast that is like not doing a whole breast reduction, but if it's a scar that could use a little bit of a tweaking, then there's an opportunity to do that one of those subsequent procedures as well.
Are there times that you would encourage people to actually have combination surgery when maybe only considering one or staggering?
Face is classic, where someone comes in, maybe isolating 1 or 2 areas, but when you do a full assessment and show them the other areas and how one impacts and relates to the other, that I would commonly recommend doing more than one procedure within the facial rejuvenation procedure.
And the other thing, when you see patients that come in specifically when they're asking about upper eyelids, and it's not only the upper eyelid commonly, like they need to have the brow addressed, and sometimes that's confronting because it's like, no, I only want my eyelids fixed, but it's like, well, you can't fix the eyelid. Some patients you can, obviously, but some you can't fix the eyelids unless you correct the brow as well. So you
We had a
combo
case recently.
combo surgeons.
Combo surgeon. So patient saw me for she actually exact
She was
example. She specifically wanted her upper blepharoplasty
Eyelids.
done, upper eyelids, but had underestimated the role the brow was playing. So I did a brow and upper blepharoplasty, and she saw Kim for breast surgery, and Kim did a breast reduction, all in the
In
one.
the same day.
One
Yeah,
anaesthetic, one thing.
Did you guys high
Tag
five
teams.
on the way in and out?
Yeah.
Yeah,
Nice.
totally.
Well,
Hell yeah.
it was an interchange. The anaesthetist made the change, put the number up, RB,
Yeah.
BN, KJ.
Was it the
Yeah.
same anaesthetist for the whole thing?
Yeah.
Same hospital.
And we
too.
didn't,
But the anaesthetist,
we didn't do the procedures at the same time because the space-wise is a bit...
you pull a little too hard on the chest.
Yeah.
And
Yeah.
she's blind.
Yeah, like, well, if he pulled hard enough on the brow, she wouldn't have needed it.
Yeah.
Breast lifted.
Yeah, that's the way it works.
Any final advice?
I think go into your consultation with your priority list if you're thinking about multiple areas, but then listen to your surgeon and their advice about why they either want to combine things or split them up. But I think have in mind that it's not all going to be done necessarily in one operation.
Yeah, I think if we're recommending splitting them or more than what you actually came in necessarily concerned about, it's not because we're trying to upsell it. We're trying to get the best outcome for the area that you have of concern.
Yeah. Nice.
Done.
Great. If you liked that episode, there's plenty more where that came from. Maybe start with some of these or head to our channel for your peek into the mysterious world of plastic surgery.